I'm Dr. Devin Eckhoff, and I'm the Chief of Abdominal Transplantation, as well as the Director of the Liver Transplant Program at UAB. I would like to give you a brief introduction about this video that we have prepared for you. This is to help guide you through the transplant process, from the transplant evaluation to the transplant itself, as well as the post-transplant care. Transplantation is a team sport, so that you're going to hear from many people that are part of our teams, from liver transplant surgeons, coordinators, pharmacists, transplant hepatologists. They all will give a part and describe the experience that you'll have and their expectations for this. UAB has a long history of transplantation, starting in 1967 with the first kidney transplant at UAB. The liver transplant program started in the late 1980s, and we've done over 2,000 liver transplants since that time. We have some of the best results for both patient survival in the country, if not the world. We have a long and proud history of transplantation, and we feel that this video will allow you to become an integral part of the transplant program at UAB.
Hello, I'm Rashay Robinson, a liver transplant coordinator, and today we'll be going over in class what is UNOS and what is a MELD score, how do you get on the wait list, what you do while you're on the wait list, and when you're called in for transplant. And at the end, we'll go over who's on our transplant team. So UNOS is the United Network for Organ Sharing. They are the organization that governs all of the transplant centers in the United States, and then just make sure that all the sickest patients are getting transplanted. They also have a great website. So if you have time, you can go to unos.org and just look over some of the transplant information. They also have a toll-free number that you can call if you have any questions about anything. The MELD score, MELD stands for Model for End-Stage Liver Disease, and that score ranges from 6 to 40. 6 is the wellest patients and 40 is the sickest. UNOS uses this score to ensure that the sickest patients are the ones getting the organs. So we get that score by using your total bilirubin, which is your liver function, your INR, which is your blood clotting time, your sodium, and your creatinine, which is your kidney function. So we put those labs into the system, and it gives us the number, which is your MELD score. So once you're on the transplant list, this number is what determines your place on the list based on your that MELD score and your blood group. And you can also calculate your MELD score at unos.org. They have a calculator on there, so if you happen to get your labs locally and they give you a copy of those labs, you can enter your own labs and see what your MELD score is. So once you're on the transplant list, your MELD score has to be updated at certain intervals, determined by what your MELD score number is. So for instance, if you're a 25 or higher, you're generally one of our sicker patients. So we want those patients to, and UNOS wants those patients to have their labs updated every 7 days, just so we can keep a closer eye on you. And if you notice, those labs also must be entered into the system within 48 hours of the draw. So if they arrive in 3 days, then those labs have expired and we're no longer able to use those. So for those patients, we want you to have your labs drawn, say on a Tuesday or Wednesday, just so we have the full 48 hours to get those labs in our system. Because we are not here on the weekends, so if, just say for instance, if you have them done locally on a Friday and your local lab sends those results to us over the weekend, by the time we get to work on a Monday, then those labs have expired. So then you're going to be going back again to get labs done. So Tuesday or Wednesday is best for those patients. And then as you see, as the score goes down, the 19 to 24, you only have to have your labs done every 30 days. And then we have 7 days to get those in the system. If those labs are not updated by that date that we send to you, then your MELD score drops down to a 6, which is going to put you at the bottom of the list. So you definitely don't want that to happen, especially if you're one of those sicker patients. And then the exception to that would be the MELD exception. So for our patients that have liver cancer, those patients, you have to qualify to reach the criteria, which for one tumor, the tumor must be between 2 and 5 centimeters. For 2 to 3 tumors, they all must be less than 3 centimeters. And once you're on the transplant list, the transplant surgeon will apply for those exception points. And once they're approved, you will go up to a MELD score of 28 after the 6 months. Also, hepatopulmonary syndrome can receive additional points. So for that, when you come in for your evaluation, we will do an arterial blood gas, which is sticking of your wrist. And on that, your oxygen level has to be less than 60. And you also have to have pulmonary shunting. If you meet those 2 criteria, then the surgeon will apply for the points. And those patients, if approved, will receive 22 points. How do you get on the wait list? Complete the evaluation process. So everybody that's on the transplant list has done exactly what you're doing this week, or what you will be doing during your evaluation. Every Monday, the transplant team reviews everyone's different test results, and if we decide to accept you as a transplant candidate, then we will request an additional insurance approval. If that insurance approval is granted, then we will get you on the list, and then you will receive your official listing letter, which will also have your MELD score and the date that you're due to have your MELD score updated next. Questions answered by the evaluation. Of course, we want to know if the risk of the transplant is going to be less than those of what you're living with today. So we want to make sure and check your heart, your lungs, your kidneys to make sure that they can tolerate the process of transplant. We also want to make sure that you have family members or support people that are going to be there for you before transplant and after transplant. We also want to make sure that you are involved in your health care because, there's going to be a time when you are the one responsible for getting your medications, getting yourself to clinic, and getting yourself to the lab to have your labs drawn. So we want to make sure that you participate in your health care also. Also your financial resources. So we just want to make sure the cost of surgery and your copays and deductibles work out okay for you for what you're going to have to be paying. So the risk of the evaluation, you may potentially have an allergic reaction to the contrast dye. A lot of patients have never had contrast dye until they come to the evaluation, so that's something that sometimes we find out during the evaluation process. You also may have minor bruising from the lab sticks, small exposure to radiation from the scans that we do, and then you also may have a new diagnosis of something that you previously did not know about, which if that's the case, then we will refer you to to the physician that could follow up on that for you, depending on what that diagnosis is. And then these are the tests that everyone goes through for evaluation. The only exception is the nephrology consult on the bottom would be for our patients that may potentially need a liver and a kidney transplant. So we would send them to see the renal doctors to be evaluated to see if they're truly need both organs. The benefits of transplant, obviously, during this week you will increase your knowledge and understanding of what's going on with your liver, and then you also have the possibility of being placed on the transplant list. Now, it's important to know that even if we decide that you're a candidate for transplant, that does not mean that you have to have a transplant. It's your decision up until, if you decide that you don't want to have a transplant, that's always your decision. The possible benefits of receiving a liver transplant. So we want to extend your life and improve your quality of life. So we want to get you back to the way you were feeling before you got sick. The risk of transplant surgery. So all of these are risk really of abdominal surgeries, except for the bottom, and so it's transmission of disease from the donor, which obviously is specific to transplant. So we like to go over that a little bit more. These are our standard donors. So we have our standard criteria donor, the increased risk donor, the KDPI or the kidney donor profile index donors, and then the hepatitis C donors. So we like to go over those a little bit more. So the increased risk donors, all donors are checked twice through blood tests to make sure that they're not positive for HIV, hepatitis C, those type things. So they all have to be negative. What makes a patient or a donor an increased risk donor is if they have a high risk lifestyle, or if they've been involved in a automobile accident or something like that, where they've had a lot of blood products. So no organs will be used that obviously have active infection. And something else to note is that our organ center uses NAT testing. So where UNOS requires the 2 blood draws to check for these diseases, our organ center does additional testing, the NAT testing, which is not required by UNOS, but our organ center does that. So it's more specific. The important thing to know about this is if you do accept an increased risk donor, you will sign a consent. And if you do not accept this donor, there will be no penalty to you as the patient. So they just go to the next person on the list. Okay. And then if you have a kidney transplant also, then you could be offered the KDPI. So that would only be for the kidney patients, and you would also sign an additional consent on that. And that would increase your chances of getting a transplant if you decided to accept one of those organs. Then for hepatitis C. So now that we have our great hepatitis C drugs to treat hepatitis C, our patients that still have hepatitis C have the option of getting a hepatitis C organ. Now, you would not want to take this organ if you've previously had hepatitis C and have cleared virus, or if you're currently in treatment for hepatitis C. So if you have not been treated or not cleared virus previously, then you can accept one of these organs, which would increase your chances of transplant. And then you would also sign a consent for the hepatitis C organ. So obviously we would not accept any organs that we don't think are appropriate for you as the patient. And so other medical risk. So the new liver may not work as it should, and that's generally something that our physicians will notice within, approximately 48 hours. And so if needed, then they could request that you be relisted for transplant. And from there, then it's generally, a couple of days, depending on your medical status, for you to get re-transplanted. Then with rejection, that will be discussed a little bit more with the post-transplant coordinator, but that's something that, a lot of times we can tell, by your symptoms and by your labs, and so that will be, dealt with in clinic or, the hospital at whatever time that comes about. Complications from anti-rejection medications, the pharmacist will go over that also, but there are things that if you have problems or symptoms that come up after transplant that you were not having before, then just let us know that in clinic, and that way we can address those with the physician. So the mycophenolate is something that we like to go over just a little bit more pre-transplant and post-transplant, because mycophenolate is one of our immunosuppression medications that we use, and it can cause birth defects during pregnancy in the first 12 weeks. So it's something that if we have patients that are on CellCept, we want you to let us know before you get pregnant so that we can take you off this medication. Or if you're a caregiver that's going to be handling medications, if you get pregnant, that's something that you need to be aware of also. So in the first 12 weeks of pregnancy, it can cause birth defects. So it's just something you need to stay away from if you're pregnant. So once your evaluation is complete, then we will discuss your case in our conference on Monday afternoons. The conference is usually at 4 o'clock. We discuss everybody's case individually and look over all of your testing and all of your records. And from there, they will make a decision. And with that decision, you will get a letter within 7 to 10 business days. The letters will say either you're listed, not listed, or if there's additional testing that we need, we will send you a scheduling letter for those appointments. So if you're not listed, then we still want you to follow up with UAB hepatology. Just because if you're not listed now, you may be listed in 3 months or so. Also, you could potentially have a TIPS or surgical shunts or the radiofrequency ablation. Those are alternatives if you're not listed for transplant. Reasons that you may not be listed is if you're early for transplant. So just for instance, if your MELD score is less than 15, because generally we want to list people that are above a 15. So if you're a MELD score of 12, you may be considered early for transplant. And that just means that the physicians don't think that your liver's sick enough for transplant at this time. So like I said, depending on, how you're doing, they may want you to follow up in 3 months, 6 months, or 9 months, just so they can keep an eye on you. And you may not be a candidate for transplant now, but you may be in the next visit. Also, psychosocial concerns. So if you're having any issues with insurance, your medication coverage, or just say if you don't have a caregiver, those are things that we take into consideration before we list someone for transplant. Also, if you're not abstinent from illegal drugs, alcohol, or tobacco, you will not be listed for transplant after you come for your evaluation. And then, depending on which one of those is positive, will determine your follow-up for that. So, for instance, the nicotine, we want to have two negative nicotine screens afterwards, just to show that you truly have quit. And then with illegal drugs or alcohol, there's a 6-month abstinence period. If you have increased medical risk that are not related to your liver, for instance, if you have a heart condition, that's something that we're going to want to check into further before we list you for transplant. So depending on what it is going to determine your follow-up, whether you need to see cardiology or a pulmonary doctor or a kidney doctor, just, depending on what that other medical condition is. So that will require follow-up. If you're morbidly obese, if you have a tumor outside of UNOS criteria, so earlier when we were talking about the exception points and those centimeters requirements, so if you're outside of that, then you would not be listed after your evaluation, but that will determine the follow-up, just depending on what size your tumor is. Also, if we find that you have cancer outside of the liver, then you would not be listed for transplant right now, because once we give you the immunosuppression for your transplant, then that cancer would be able to basically do it at once. So depending on what type of cancer it is and where it is going to determine the length of time before being listed for transplant. So multiple listings, you can be listed at multiple transplant centers. The biggest thing with this is that you have to get approval from your insurance company to go to the third site to get evaluated, and then it would be, of course, up to that facility whether you would be listed for a transplant or not. If you're listed at multiple places, that would decrease your, could potentially decrease your length of time on the transplant list. Also, transferring waiting time. Just say if you get listed here at UAB, and then for some reason you have to move, to a different state. Your insurance company, if they agree to have you do an evaluation at another facility, and then you get listed at that other facility, then we could transfer the time that you've accumulated here to that new facility, and that way you still keep all of your time that you've been on the list. Planning financially for your transplant. So of course everyone's financial situation is different. So we like to take everybody's specific situation, into consideration. Like I said earlier, we want to, look at all your deductibles and your copays, so that you know how it's going to affect you. Also, if you have any additional fees for physicians, so radiology, if you have any additional fees for surgeons, or for rehab, if you possibly need to go to rehabilitation after your transplant, if that's going to be an additional cost for you. And then so the non-medical cost, things that you have to think about is, food, phone calls, lodging, travel expenses. So if you're someone that lives 30 minutes away from the hospital versus someone that's 4 hours away from the hospital, obviously that's gonna, include additional expenses for you. So those are things to think about. If you have child care, pet care, any of those things, then those are things, obviously that you need to think about. If you do not have sick time or vacation time and you have to take days off of work without pay, that's something else to think about. And then make sure and talk to your case manager with your insurance, because they're going to be the ones that's going to be able to give you all the details of what's covered by your insurance company. Medicare certification. UAB is Medicare certified, but if you go to a different facility, make sure that they are Medicare certified as well, because even if you are currently not using Medicare, once you get into the Medicare realm, they will not reimburse your immunosuppression medication if you're not transplanted at a certified facility. So for all transplant costs, they may not reimburse, which is going to end up being a lot of expense for you. And these are our statistics. So these are updated every 6 months through SRTR, and these are also online. And basically the top portion of the slide is for the actual organ. So it says the liver. The bottom portion is for the patient, so that's why the numbers are different. So earlier when I was saying that someone may need to be retransplanted, obviously that first organ did not do well. So that's why the numbers on the top are lower than the numbers on the bottom. So the 91% would be, just say out of 100 patients, then 91 of those survived after a year. And it's also important to note that these statistics include anyone that has expired for any reason. So it's not just liver-related deaths during that first year. So what happens while you're on the transplant list? Pack your bags and be ready at any point, because we can call you at any time. We could call you at 5 o'clock in the morning. We could call you at 2 o'clock in the morning, 5 o'clock in the afternoon. So just be ready to come into the hospital at any point that we call you. So just make sure and have your stuff together, including your medication list and your phone list of who you need to call. Make arrangements for child care, pet care, and home care. Make sure and have travel arrangements made, and I would recommend having multiple options for transportation, because you don't know if the first person that you have chosen to come with you for transplant is going to be available. There could be some unexpected, something come up to where they're not able to bring you to the hospital. So I would recommend, even as a fourth choice, to ask a neighbor or somebody from church or a friend or something, just say, if all of my other options are not options, then would you be able to at least bring me to the hospital and be there with me when I go for transplant. Also, keep your cell phone on and charged, and answer it if we call, because we could be calling you from any number. It's not necessarily going to be from our office number. So our call phone number is a different number. If we happen to not have the call phone, or if it's not working, then we may call you from our cell phone. So it's just something to where once you're on the transplant list, make sure and answer any of the phone calls that you receive, just in case it's us calling you in for transplant. And then, of course, arrange for your support person that'll be there with you after transplant. And while you're on the wait list, make sure and update your coordinator with any changes in your phone number, your address, and your insurance. So make sure and let us know if your phone number changes, because that's how we're going to be in touch with you to call you in for transplant, or to update you with any changes that we see, with your medical status, with your address, because that's how we're going to send you your letters, so you'll know when you need to update your score, so that you stay active on the transplant list. And then, of course, with your insurance, because if your insurance changes and we're unaware, then that could be a problem after transplant. So if you think that your insurance is going to be changing, just go ahead and call your coordinator and let them know that potentially at the first of the month this insurance could change, and that way we could be prepared for that. Also, let us know if you become pregnant. So while you're on the wait list, you still need to follow your primary care physician, because they're still going to be the ones that are going to be handling your high blood pressure medication, your diabetes medication, any of those other things. They're still going to be the ones to do that. You will have periodic checkups at UAB, and that's just going to be, so we can keep an eye on you, and depending on how sick you are is going to determine how frequently you come back to see our physicians. So it could be every month, every 3 months, every 6 months, so on and so forth. Also, maintain your annual screenings. So if you just say if you're one of those HCC exception point patients, you will need to have your abdominal CT scans and your AFPs done every 3 months once you're on the transplant list. But in addition to that, you need to have mammograms and pap smears for females and prostate exams for our male patients. If you happen to have any chest x-rays, EKGs, anything like that that you need on a regular basis, then go ahead and maintain those also. So whenever we call you in for transplant, you need to be to the hospital within 6 hours. There's a map and the information that you receive before you come for your evaluation. So while you're here for your evaluation, if you want to go ahead and try to familiarize yourself with some landmarks, and that way if we do call you at 2 o'clock in the morning, you're not trying to figure out where you're supposed to go in an unfamiliar place. Let your coordinator know when we call you for transplant. Let us know if you've recently been sick or had a fever. We will ask you that question, but just make sure and be honest, because it's something that if you have been sick, we'll communicate that to the surgeons, and that way collectively, they can make a decision of, if they still want to bring you in for transplant or not. We just don't want to get somebody here and then find out that you're running a fever, and then we may not, be able to use that organ for you, or be able to have time to get somebody else here to use that organ. Do not eat or drink anything unless we specifically tell you that you can, because you have to be without food or fluid for 6 hours before transplant. So if we know you're not going to go to transplant until the next day, then we may tell you could go ahead and have a light dinner or something like that. But you also may be going to surgery in 5 hours. So just do not eat or drink anything unless we specifically tell you that you can. Also, your family members need to make hotel arrangements for the first 1 to 2 nights, because you'll be in the ICU, and we don't really want family members sleeping in the waiting room. So just go ahead and plan for that once you're called in for transplant. When you're called in for transplant, you need to bring, of course, your insurance card, any prescription cards, eyeglasses, glucometer, with the supplies, so with the strips and all that good stuff. Also, bring your medication list. Go ahead and bring your medications with you, just in case there's a question about something. They actually have the bottles there to look at. And then, of course, your money for your co-pays, and, of course, a family member. And then the surgery will last about 6 hours. From there, then you will go to the ICU for 1 to 2 days. After you're discharged from the ICU, you will go to the floor. You'll be on the floor for about a week. During that time, you will be learning about your incision care, your new medications, because you'll be off of a lot of medications that you were on and on a lot of new medications. And then also physical therapy will be coming and working with you to get your strength back up. So it's very important during that time in the hospital that you have a caregiver there with you, so that your caregiver can also learn all of these things, because they're going to be the ones that are going to be helping you get around and do your medications once you're discharged from the hospital. Once you are discharged from the hospital, you will go to the townhouse if you live farther than 30 minutes away from UAB. If you live within 30 minutes of UAB, then generally you're able to go home. But if not, like I say, you'll go to the townhouse. From the townhouse, you'll be going to clinic 2 to 3 days a week, generally on Mondays and Fridays. Before every clinic visit, you will always have labs done, and then go up to see the surgeons in clinic. And the townhouse has linens and dishes, but they do not provide food or maid service, so it'd be just like you're at home, so you'd have to take care of those things yourself. They do provide a washer and dryer in the bottom floor of the townhouse, so that you don't have to go out of the facility in order to do the laundry. So the biggest thing post-transplant is to be compliant with your medication, the dosage of medication you're supposed to take, your clinic visits, and your lab draws, because that's how we're going to tell if anything's changing with you. So we want to make sure that you have a well-functioning liver. So make sure and do the things that we ask you to do after transplant. Your labs can be done locally. pre-transplant and post-transplant. The thing that we ask is if you have labs done, even if you have them done at UAB at the Kirkland Clinic, when you are seeing one of our physicians pre-transplant, then go ahead and call the coordinator office and let us know that you're having labs done, because the lab does not know that you're a transplant patient, so they don't know to call us and let us know. And so if we're waiting to get labs for a MELD score update, then that time could potentially pass and those labs expire before we even realize that you've been here to have labs done. So just go ahead and give us a call pre-transplant every time that you have labs done. You will still need to follow up with your primary care doctor once you go home, about a week or two after you get home from your transplant, just so that you can update them on everything that's changed with you since your transplant. And that way you're not trying to do that on a day that you might not feel as well. So just go ahead and see them within a week or two after you get home. Our transplant surgeons are Dr. Eckhoff, Dr. Gray, Dr. Tector, and Dr. White. And then our hepatologists are Dr. Kadali, Dr. Masood, Dr. McGuire, Dr. Shariba, and Dr. Simpson. And then our neuropsychologist is Dr. Thurston, which not everybody sees him during the evaluation. And then our inpatient nurse practitioners and our outpatient nurse practitioners, those most everyone will see after transplant, unless you happen to be a liver cancer patient, then you may have already met those nurse practitioners before transplant. And then our social workers is Amy Holmes and Bridget Wright, which are outpatient social workers. And then Kristen Merrill is the inpatient social worker. So she'll be the one to get you set up with a townhouse and stuff like that after transplant. Our financial coordinator is Angela Fowler, and she's the one that we send your information to get insurance approval. Our pre-transplant coordinators are Tiffany Cheeks, Kim Rayner, myself, I'm Rashay Robinson, and then Erica Taylor. And then our post-transplant coordinators are Michelle Cagle, Becky Campbell, Peggy Corcoran, Letizia Haywood, and Brenda Meharry. And we divide each of the patients up by the first letter of your last name, so that's kind of how that goes. And our transplant assistants are Andrea Hall and Kim Jones and Anna Sellers. And they all answer the phones whenever you call our office. So if there's anything that you have questions about, then you can ask them and they will give us the question. So hopefully when we call you back, we'll be able to give you that answer. And then on the last slide is all of our numbers, important numbers that you need to know. So the number to our office, the fax number. So if you have colonoscopies, EGDs, or upper GI, mammogram, pap smear, stuff like that, then you can have those faxed to the 975-2298 number. And then for social work, that number's on there. And then, of course, to the liver center. So if you need prescription refills pre-transplant, then you would call that number to get that from the hepatologist that you saw during the evaluation.
We're going to now talk about your liver transplant evaluation. The process of being listed for liver transplantation is a multi-step process. One of the most important parts of this process is you being referred here for transplant evaluation and undergoing the transplant evaluation. Even if you feel that you're early for transplant, it's important that you complete the entire evaluation. The model for end-stage liver disease score was developed originally to describe the 3-month mortality following shunt procedures. It's currently utilized to determine allocation of livers for transplantation. The score ranges from 6 to 40 and is based upon 4 laboratory values: the sodium, the total bilirubin, the INR, and your creatinine. Within blood groups, the patient with the higher MELD score will receive an organ offer first. There are exceptions to this based upon the diagnosis of cancer, as well as clinician determined increased mortality risk among the potential recipient. So therefore, if I feel that this MELD score does not adequately reflect your risk of dying, I can appeal to a regional review board to ask for additional points. There are also some diagnoses which automatically come with additional MELD score points. It is very important, though, that you keep your laboratory data up to date, because these scores have to be reran from time to time. Patients are oftentimes very concerned about where they're at on the transplant list. It's important for you to remember that the most important step in this entire transplant process is maintaining an active status on the list. This next slide shows the average one-year mortality rates based upon MELD score. And it is felt that the benefit of transplantation is achieved when your MELD score is over 15. Once you're on the list, you need to realize that you can be called in at any time. From the moment you are active on the list, it is entirely possible that you could be called in for transplantation. Now, it is unlikely with a lower score, but it's still a possibility. So you need to be ready in order to come in to receive an organ. Currently, our median time to transplant is approximately 5 months, and our median MELD transplant ranges from 21 to 30. It is important while you're on the list that you maintain your functional status, and that means that you maintain walking or some form of exercise. This is beneficial because it will allow you to undergo a safer transplant, and you will also recover from your transplant faster. It's important that you keep us as the transplant professionals aware of your medical condition. If you're admitted to an outside hospital, or you feel that your medical condition is getting worse, it's important that you let us know. We like to solve problems. We can only solve problems that we know about. Now we'll talk about the differing donor types. These include split livers, donation after cardiac death, as well as donors with positive serologies. First, we'll talk about split livers. Split liver transplant means how we take one liver and we're able to split it and offer it to 2 different recipients. This type of organ is determined based upon the quality of the organ offer as well as the recipients available on the list. The size of the recipients is very important because we want to avoid what's called small for size syndrome, in which the recipient does not receive enough liver in order to recover. With this type of donor, we're more concerned about vascular complications. Although the rate is low, it is increased from a standard whole organ transplant, as well as the risk of bile duct complications. The second donor type that we can offer you is a donation after cardiac death. These are donors in which the family has decided to withdraw care, and the donor is likely to expire within a short period of time from the withdrawal of care. There is almost nearly equivalent patient and graft survival with this type of donor, although we do worry more about biliary complications, specifically an ischemic cholangiopathy with this type of donor. It is important to remember, though, at the time that an organ offer is made, with any organ, but especially with this organ, that you may make a trip into the hospital and the organ may be determined to be unsuitable for transplantation at the time of the procurement, in which case we would not offer that organ to you and we would send you home to remain active on the wait list. The third organ type that we'll talk about is donors with positive serologies. So for example, if we have a donor who has hepatitis C, we would test that donor by getting a biopsy to make sure that liver is usable, and then offer it to our recipients on the list with untreated hepatitis C. Studies have shown that the hepatitis C positive recipients who receive hepatitis C positive organs do as well, if not better, than had they received an organ without hepatitis C. Second type of organ with positive serologies would be the organ from a patient who is hepatitis B core positive. We offer these to our patients who have previously been immunized against hepatitis B or patients who actively have hepatitis B. The major difference with this is how we would require one additional medication in addition to immunosuppression to prevent activation of the hepatitis B. Lastly, we'll talk about the risk of donor-derived infections. It is important for you to remember that any organ that we offer you carries the risk of bloodborne pathogens coming along with the organ transplant. We test all of our donors utilizing a nucleic acid test as well as an antibody test. The nucleic acid test is very specific as it looks for DNA and has a shorter window. The serologic test is looking at antibody and has a little bit of a longer window and is felt to be not as specific. There are certain donors that have been designated as being increased risk. This is based upon donor behavior or medical criteria. Donor behavior would include things such as donors who are incarcerated, or donors who are involved in high-risk sexual activities, or donors who have IV drug use. There are certain donors that are considered to be higher risk for these. We test all of our donors here the same way, with both a nucleic acid test, which is very specific, which is a DNA test, as well as a serologic test, which looks for antibody. Donors are designated as being increased risk based upon donor behavior as well as medical criteria. Donor behavior includes things such as their donor's prior sexual activities, if they've been incarcerated, if they have been involved in IV drugs in the past, and then medical criteria would include things that are determined at the time of donation based upon a physical exam, as well as the amount of blood product in which the donor may have received prior to donation. When screening donors with the serologic testing alone, which is less specific than the nucleic acid testing, there is a 1 in 50,000 risk of the donor actually having HIV when they have a negative test. When the donor is considered to be increased risk, this risk of HIV increases to 1 in 10,000. The risk of hepatitis C in a normal donor without any of those behavioral risk factors is around 1 in 5,000. The risk when you include donors higher risk based upon those risk factors is 1 in 1,000. The risk of you dying on the list without an organ transplant is 1 in 5. Therefore, we feel it's safe to offer you these increased risk organs because, one, with the nucleic acid testing, it decreases this risk even further, and then secondly, it is a life-saving procedure.
I'm Jared White. I'm one of the liver transplant and hepatobiliary surgeons at UAB, and I'm going to talk to you about the technical aspects of the operation and the post-operative follow-up to expect in the first 6 months. So you've already been evaluated for liver transplant and found to be an acceptable recipient. So at this point, an appropriate blood group donor has become available. You'll be instructed to travel to UAB for admission. On average, it may be anywhere from 6 to 24 hours or more before the operation begins, so you have plenty of time to get to the hospital and get checked in. We began with a pre-op workup that includes labs, blood work, chest x-ray, EKG. You'll also meet with our anesthesia staff and get all of your consents and paperwork signed. The surgical and anesthesia staff will answer any last-minute questions that you or your family may have. Once you're taken back to the operating room, you'll be placed under general anesthesia, which is much like any anesthesia you've had during previous surgeries. We'll place a catheter in your bladder as well as a gastric tube in your stomach. You'll have a series of IVs, an arterial line in your wrist, as well as a venous catheter in your neck. We'll begin your IV immunosuppression that will begin during the transplant procedure. Your abdomen will be prepped and draped and sterilized appropriately. The procedure itself typically takes somewhere between 4 and 6 hours or longer, and a lot of that depends on any prior abdominal surgeries, any history of peritonitis you may have had, or vascular complications such as portal vein thrombosis. You'll have a large incision. We call this maximally invasive surgery, and a couple of those incisions that we'll use, one of which is a midline incision with a right subcostal extension that goes below the right side of the ribs. Occasionally we'll use a bilateral subcostal incision or even a Mercedes type incision where you have a midline and a bilateral subcostal, and that's all based on your body habitus. We'll place our retractors that will crank up on your ribs and allow for exposure, so you can expect rib, chest, and back pain from that retraction during surgery. Your liver will be removed, and we preserve all the necessary structures for the transplant, including the vena cava, which is the large blood vessel behind the liver that attaches to your heart. We preserve your hepatic artery for the arterial inflow, the portal vein for the venous inflow, and then the bile ducts to drain the bile from the liver into your intestines. In some circumstances, such as primary sclerosing cholangitis, or if you have an abnormally thickened or unpreservable bile duct, you may need a RULM, which is a loop of intestines that we bring up, and anastomose to the liver for the bile outflow. If you have an unacceptable artery that's thickened or diseased, we may have to perform what's called an arterial aortic conduit off the aorta. Some patients have portal venous thrombosis that precludes being able to connect the portal vein, so we have to do a venous conduit. Very rarely, less than 1% of the time, do we have to place patients on veno-venal bypass for the procedure. Once the procedure is performed and the new liver is sewn in, we typically place a series of anywhere from 1 to 3 drains that will help collect blood or ascites or occasionally bile from the liver. Those drains are typically removed during the hospitalization and prior to your discharge. In some patients, we place what's called a T-tube, and that is in the bile duct and drains outside of the abdomen through a small rubber tube that you'll keep for 6 months, and we typically remove it at 6 months. A majority of patients receive an endobiliary stent, where the stent's on the inside of the duct, and that's typically removed at approximately 2 months with an EGD. Frequently, some patients require trips, 1 or more trips back to the OR following the original procedure, and that's typically done in cases of intra-abdominal hemorrhage or bleeding to wash out any hematomas, or if there's any evidence of bile leak. Occasionally, if there's technical complications such as thrombosis of the artery or vein, or if there's leakage of bile or concern for stricture, we'll go back to the OR pretty aggressively to take care of those issues. Rarely, less than 5%, probably closer to 1% of the time, the donor livers, for any number of reasons, may not work, and we call that primary non-function of the transplant. And that may require urgent relisting, where you go to the top of the list and we find another donor liver that will hopefully be available and will work. That can be a fatal event if we're not able to get you retransplanted within about 3 to 5 days or less. So that's rare that happens, but occasionally we see that. Following the procedure, you're transferred to the ICU. You're still on life support. You may be getting blood, platelet, or plasma transfusions, maybe on insulin drips or other cardiopulmonary drips for your cardiac function. You're still on the mechanical ventilator, basically waiting for the liver to function and for you to wake up and follow commands. Once you're awake and criteria is met for extubation, the breathing tube is removed, and that typically happens anywhere from 1 to 24 hours after the procedure. Once you're extubated, things move reasonably quickly from there. We get the catheter out of your bladder and the NG tube out of your stomach. We start ambulating you as early as day 1. Once you get the breathing tube out, we get you up and out of bed. We'll start you on a diet, typically clear liquids, and advance that as tolerated. We transfer you from the ICU to the transplant floor once you no longer need critical care. And then we begin your post-transplant medications and recovery. Some of those medications will be your immunosuppression, which will be new medications, and you'll also lose some of the old medications that you were on to manage your cirrhosis. We place you on infection prophylaxis, and we monitor your comorbidities such as hypertension, diabetes, and so forth. In terms of the medications, the immunosuppression, there are several agents that we use, and we'll talk about some of those side effects. You'll have pain medication initially with a pump that you can control your pain regimen, and then as you begin eating, we'll place you on oral pills. Most patients need a bowel regimen either for constipation or diarrhea and the other side effects of surgery. Some common things that patients experience would be worsened diabetes, occasionally hypertension, high cholesterol, and renal dysfunction. In terms of the immunosuppression medication specifically, nausea, headache, diarrhea, and constipation are common. Of course, postoperative pain from the surgery is very common. Some patients experience seizures or mental status change for a period of time. Poor appetite, fatigue, shortness of breath, all of these are common after the transplant procedure. In general, most patients stay between 5 and 14 days. Day 5 is about as early as you could expect to make it out, on average somewhere between 10 and 14 days. A lot of this is affected by your pre-op condition and how strong you are. Patients who are bedridden tend to stay longer. Small percentage of patients may stay from weeks to even months patients who are on dialysis, who have a difficulty ambulating, have cardiopulmonary disease, for example. If there's complications from surgery or other issues such as infections or rejection, you can expect a longer hospitalization. Some patients even require discharge to a rehab facility in order to continue their post-op recovery. In that first month, the expectations are that Monday and Friday you'll be seen in our post-transplant clinic. There we're monitoring you closely for graft function. We're checking your liver function labs as well as your renal function, managing your comorbidities as well as the side effects from the medications. We are repleting electrolytes and closely monitoring your renal function. If you live within 1 to 1.5 hours from UAB, you tend to be able to be discharged home, but for those patients who are from farther away than about an hour and a half, you can expect to stay at our UAB townhouse or locally if you have family or friends. Your staples from your incision are typically removed around 3 to 4 weeks after the procedure. And after about 1 month, if all is well and you're tolerating your medications and your graft function is good, you'll typically be discharged home, and we'll follow up anywhere from 1 to 2 times per month. You'll get labs locally at your primary provider or a Quest Diagnostic Center that's close to home, and have those results faxed to our office. Occasionally you may have to return to clinic for any specific problems if you're having graft dysfunction or major lab abnormalities in the meantime. At about 6 months out, if you have a T-tube, for those patients that received a T-tube in the OR, you'll have a cholangiogram, and that T-tube will be removed in clinic. A small percentage of patients will experience a leak when that T-tube is removed, and you'll know that right away due to a new onset of pain. We'll bring you in the hospital from that clinic visit and get an ERCP where a stent will be placed, and you'll typically be discharged home the following day. If you have an endobiliary stent, that's typically removed around second month after surgery, and that's removed with an EGD. That's an outpatient procedure. You'd be discharged home following that. If you're having no other issues, you're experiencing normal graft function and tolerating your medications, and all is going well, at the 6-month visit, we'll transition you to our post-hepatology transplant clinic, where you'll be followed a little less closely, maybe a few times a year to once or twice per year, and your care will also be expected to continue with your primary care provider.
Hi, I'm Michelle Cagle, and I'm one of the post-liver transplant coordinators at UAB Liver Transplant. Today I will talk to you about post-liver transplant care and what to expect after hospital discharge. Once you are discharged from the hospital, you will be expected to follow up in our Kirkland Clinic with our transplant surgeons. We will ask that you be in our second floor lab by 6:45 a.m. and once you've had labs drawn, proceed to our 5th floor surgery clinic. At each clinic visit, you will see a transplant surgeon, a nurse practitioner, a pharmacist, and a nurse coordinator. Points to remember during your visit are that while you're at the townhouse, visits will be approximately every Monday and Friday. Again, labs should be drawn no later than 6:45 a.m. We ask that you do not eat, drink, or take your medications prior to your lab draw. However, please bring all medications and your medication list with you when you come to clinic. Be sure to keep up with the amount of medications that you have so that you can ask your pharmacist for refills during your clinic visit. If you have any questions or concerns, please write those down and be prepared to ask when in your visit. And upon leaving your clinic appointment, always be sure to stop by the checkout desk to schedule your next appointment. It is very important that you keep up with these clinic appointments. Reasons to call the coordinator. These are important reasons to call us, but not an all-inclusive list. Among these are a fever of 101.5 or higher. If you have pain that is severe or constant, you know the type of pain that you're having immediately after surgery. This should be decreasing as time goes on. However, if this is changing acutely, or again, if it's severe or constant, please notify us. Be sure to monitor your surgical incision every day. If you notice that it's becoming red, swollen, inflamed, hot to touch, or is having drainage that is yellow or green, again, please call us. Yellowing of the eyes or yellowing of the skin should be getting better with time, but this is one reason why we ask a family member to stay with you 24/7 initially after your surgery. They can help assess this even when you may not notice. If you are having vomiting or diarrhea that lasts for more than 24 hours, contact your coordinator immediately so that we can ensure to treat you so that you can maintain your medications to prevent liver transplant rejection. If you have a cough that produces yellow or green sputum, or if you have a cough that lasts for more than a week that is dry and non-productive. If you have a rash or any other skin changes such as bruising easily. If you have vaginal or penile discharge or burning with urination, please let your coordinator know. During the time of your surgery, you had a Foley catheter, which puts you at risk for a urinary tract infection, and the antibiotics do put you at risk for yeast infections. Also, if you've been exposed to mumps, measles, chickenpox, or shingles, let your coordinator know immediately. Things not to do. Do not lift anything over 20 pounds during the first 3 months after transplant. This puts you at risk for creating an incisional hernia that will need to be surgically repaired in the later months. Do not have dental work performed in the first 6 months after transplant. Only in an emergent case should this be done. If it is needed, please consult your transplant surgeon first, as we will need to provide antibiotics prior to your dental appointment. Do not go swimming in pools, hot tubs, lakes, rivers, or oceans in the first 6 months. And even after 6 months, we prefer never ponds, rivers, or lakes. Do not drive for at least 4 weeks following surgery or for as long as you are taking narcotic pain medications. When you do feel that you are ready to continue driving, please contact your transplant surgeon at the next clinic visit to discuss him clearing you. Do not take NSAIDs, ever. We need you to avoid all non-steroidal anti-inflammatory drugs such as Motrin, Aleve, ibuprofen, Midol. These medications are filtered by your kidneys, and we need to reserve your kidneys for the immunosuppression meds that we are providing you. Do not take live virus vaccines such as chickenpox, shingles, or the nasal flu mist. Do not add any new pets to your household during the first 6 months, and we also ask that you avoid birds. Do not consume grapefruits or grapefruit-containing products, as this can increase the amount of medication in your system, making it toxic. We also ask that you avoid raw seafoods, raw meats, any uncooked foods such as eggs and eggnog, and unpasteurized dairy products. Do not smoke, drink, or do drugs, as always. Things to do after transplant. Follow up with your primary care physician. If you do not have a primary care physician at this time, now is the time to establish care with one. Liver transplant will not provide care for primary issues such as bladder infections, sinus infections, after 6 months post-transplant. Be sure to maintain your annual health screenings such as dermatology, gynecology, mammography, prostate, and dental once the surgeon has cleared you. Continue good hand hygiene. Think of the high-touch surfaces around you, such as doorknobs, telephones, remote controls, light switches. Make sure to keep hand sanitizer and hand sanitizing wipes on you at all times. Maintain proper care of your surgical incision, tubes, and drains. You should shower at least once a day, if not twice, with warm soapy water over your incision. We ask that during this time of your incision healing, you do not take any baths, as the bacteria floating in the water can cause an infection. So again, showers only. Be sure to use birth control to prevent pregnancy. This applies to both men and women. Be sure to talk to your transplant surgeon if you are planning a pregnancy, as they may need to adjust the immunosuppression or make changes. Sex is okay immediately after transplant, as long as you feel up to it. Be sure to keep your immunizations up to date. We will expect that annually you will have flu vaccines and pneumonia vaccines as appropriate by your PCP. Be sure to use SPF 15 or greater every day. Every time you go outside, this should be applied, and applied frequently if you're outside for long periods of time. If you choose, you can wear long sleeves and hats to avoid the sunscreen. Be sure to eat healthy and avoid fatty foods. Drink plenty of water and exercise daily. When returning to work or school, we do help provide FMLA paperwork. If you have this, please print it and bring it to the hospital when you're called in for transplant. These documents can be completed as an inpatient and returned to you so that you can return them to your facility as soon as possible. We do provide a temporary disability up to 6 months after transplant, and most patients do return to work within 2 to 3 months. If you feel after 6 months that you will need further disability, this will have to be obtained from your primary care provider or another provider to help with benefits. With regards to returning to work, school, and travel, if you have medical leave documents that need to be completed, please print those out and bring them with you to the hospital. These can be completed while inpatient. We provide temporary disability for up to 6 months following transplant. Most patients return to work within 2 to 3 months, as is the goal for liver transplant. If you feel after 6 months that you need further disability, this will need to be obtained from your primary care provider or other healthcare provider. If you would like to travel once discharged from the hospital, initially you will need to stay within 30 minutes of our transplant facility. As the surgeons grant you permission and clear you, you can travel, but travel needs to initially be for short periods of time, short distances. You do need to stop often, hydrate, eat healthy, get exercise in between trips, and make sure that you always have enough medication on hand. Tips for success after your transplant. The most important things you can do are follow up with your liver transplant clinic appointments. Have your labs drawn as requested, take your medications as prescribed, eat healthy, stay hydrated, drinking plenty of water, and exercise daily. If you follow these simple steps, you will increase your chances of a successful transplant. Our goal is to get you back to living life and living it at the fullest. We welcome you to post-liver transplant. We are so glad to have you. The following slide will show contact numbers and information. Please feel free to call us anytime.
Hi, I'm Heather Simpson. I'm one of the transplant hepatologists at UAB, and I'm going to talk to you a little bit today about long-term complications that can occur post-liver transplantation. There are a number of things I think that you need to be aware of regarding liver transplant, and I know that Dr. White and Dr. Gray and some of our other faculty have already discussed with you some of the concerns pre-transplant, and I just want to focus on some of the things you may not be thinking about right now because you don't know what to expect long-term after a transplant. There's a lot of medical conditions that patients are already going into pre-transplant, and these include a lot of complications related to fatty liver disease, which is one of the fastest growing causes of liver disease in the United States. A lot of patients with fatty liver disease have other medical problems, including high cholesterol, high blood pressure, diabetes mellitus, coronary artery disease, and unfortunately none of these problems are usually going to go away after transplant. If anything, they are going to continue to be present if they were present before transplant, and for some people who did not have these problems, they will develop after transplant long term. And this is due to a number of things. In particular, some of the medications that we put you on to help maintain your liver graft, your liver transplant from being lost to your body rejecting it, they can lead to side effects that can contribute to things like high blood pressure, high cholesterol, and diabetes. In addition, most patients after transplant tend to gain a lot of weight. The reason for the weight gain is usually kind of a multitude of issues. We do often place patients on steroids, and steroids can contribute to increased appetite. And also, a lot of people just start feeling well for the first time in a long time, and so it's kind of natural to sort of overdo some things, and one of those activities includes eating too much. A lot of people had poor appetites for many months or even years before transplant, and now for the first time, food tastes good, patients want to eat, and they eat too much, and that leads to weight gain. In addition, as you're recovering from your transplant, your activity level may not be quite up to par or to what it was previously. And as you're recovering, from this large operation with a big incision, and you're sore and you're getting over that and allowing the wound to heal, it's easy to be quite sedentary. And when you're not up and moving around a lot, you're also going to gain weight. So it's important to be aware of this, because the best way to prevent a lot of these long-term medical problems, including diabetes, high blood pressure, coronary disease, is to try to be proactive in trying to prevent them from happening in the first place, or prevent them from getting out of control. Practicing good control of these medical conditions can make a big difference in your quality of life, and also how long you can live after transplant. So one of the conditions I'd like to talk about is high blood pressure. So about 50 to 70% of patients will develop high blood pressure, hypertension after transplant. And this is due to partially the steroids that patients are placed on in the initial months after transplant. In addition, one of the common medications that we use post-transplantation is Prograf or tacrolimus, and sometimes cyclosporine, which is a little older drug, but still we have quite a few people that are on it due to not tolerating the tacrolimus. And these medications in particular have the side effect of causing the blood pressure to rise. There are things that we can do to treat the blood pressure, including a number of different medical therapies, including ACE inhibitors and medications such as calcium channel blockers. And we just need to make sure that we get you on the right dose, and that we titrate them, and basically adjust the doses based on your need. And I think an important thing to focus on is that it's very, very important to have a primary care doctor or a family medicine doctor that lives closer to you, that can help manage some of these problems as they come up after transplant. A lot of you guys live pretty far away. You're coming from 3-4 hours away, and it's just not feasible that you can get here long term, and as often as you do short term right after transplant. And you need a doctor closer to home who can help you manage these problems. And so it's important that we manage them together. If your primary care doctors have any questions about what medications are safe to use, or they're worried that they may interfere with any of your medicines, you can either call us or have your doctor call us, and we're happy to talk to them about and give them some recommendations about how to manage these problems. In addition, obesity is a major problem post-transplant. I think it's very important to try to be healthier in order to try to prevent weight gain, which will cause a lot of the medical problems to reoccur post-transplant that were present before transplant. Following a healthy diet, low-fat diet, low-carb diet, increasing your activity level, and also trying to do exercise is very important in trying to control your weight, and prevent from getting additionally overweight, and also to try to lose weight. It's a heck of a lot easier to prevent weight gain than it is to try to get weight off once you have it. As you know, it's a constant challenge, requires a lifestyle change, which that's really what it is. You can't expect to lose weight overnight. It's something that takes constant effort and constant awareness, and it's important to get out there and move, as well as to eat a healthy diet. And I think it's a lot easier to eat healthier when you realize how hard it is to burn off those calories that you're putting on. So if you need help with dietary changes, we can help set you up with a nutritionist or have your primary care doctor also assist with this. High cholesterol is another problem, also what we call is hyperlipidemia, a long-term problem that we worry about after transplant. This is often also related to weight gain and obesity, as well as some medicines that you're placed on for your liver transplant can also contribute to this. In particular, a medication known as sirolimus. We often place patients on sirolimus when they have chronic kidney problems, and it's nice in that it doesn't cause worsening kidney disease, but it can lead to elevated blood lipid levels. Luckily, there's a lot of ways that we can treat this. There's a number of different medications out there, including what we call statins. They're safe to use post-transplant. A lot of patients say, I can't take one because I have my fatty liver disease. That's not true. We just, need to monitor it and put you on the right dose and follow up on your lipids and adjust it if it needs to be adjusted. And this is also something your primary care doctor can assist with. In addition, increasing your activity really helps with control of lipids. So increased activity helps raise the good cholesterol, known as the HDL or high density lipoprotein, and makes the bad cholesterol or the LDL, the low density lipoprotein, go down. So dietary changes are very important in addition to medical therapies. Diabetes mellitus is a major problem post-transplant. This is also a big problem pre-transplant as well. As people develop cirrhosis of the liver, they develop more resistance to insulin that the body makes, and less insulin is actually produced as well, and it's not as effective. So many people have to go on insulin prior to transplant, and many people have to stay on the insulin after transplant, and that's because often steroids are used initially to help prevent the body's immune system from rejecting the organ, and this can cause the blood sugars to go up. In addition, as we talked about earlier, most patients gain a lot of weight after transplant, and this also, the weight gain, contributes to insulin resistance and the development of diabetes. So not all patients will need insulin after transplant. Sometimes diabetes can be controlled with a number of different oral medications, but I think the most important thing is just that you get good control of the diabetes, that you try to keep that hemoglobin A1C, which is the long-term indicator of how your blood sugar is over 3 months. Keep that down, try to get that down below about 7 or 7.5. And sometimes, your primary care doctor may not be completely able to manage the diabetes on their own, and that's why we have other doctors who specialize in this profession called endocrinologists or the blood sugar doctors, and we can help set you up with an endocrinologist here at UAB or locally to help you manage your diabetes. If you are able to lose a significant amount of weight, then a lot of times a lot of these medical problems will go away. Things like high blood pressure, hyperlipidemia, as well as diabetes. In addition, coronary artery disease is a problem long-term post-transplant. The number one killer in America today is coronary artery disease, and so it's not unusual that a lot of liver transplant recipients will also die of coronary artery disease, especially the patients who underwent transplantation for fatty liver disease, as coronary artery disease is part of what we call the metabolic syndrome, which goes along with a number of other diseases, including high blood pressure, hyperlipidemia, and diabetes mellitus. So I think it's, once again, important to try to live a healthy lifestyle to try to prevent coronary disease. Avoid smoking. Tobacco certainly contributes to early and more severe coronary disease. Osteoporosis and osteopenia, which is bone loss, are also common complications long-term after transplant. A lot of patients that have cholestatic liver disease, the diseases such as primary sclerosing cholangitis and primary biliary cirrhosis, they require basically closer monitoring of their bone density. These diseases tend to cause bone loss, progressive bone loss, and demineralization of the bones, which then can lead to fractures and other problems. So a lot of other medical conditions, or other liver diseases can also lead to bone loss, including diseases that require steroids, such as autoimmune hepatitis, or anybody who's received a transplant receiving steroids is going to lose some amount of bone density, usually in the first 6 months to a year after transplant. But this can be gained back through being weaned off the steroids and being more active. Activity helps promote bone health and bone turnover, and actually helps strengthen your bones. So it's very important to be proactive with walking or gentle running. It doesn't have to be going out and running a marathon, but just something getting out there and moving is important every day. Another important complication I'd like to just touch on briefly is that there is an increased risk of malignancies long-term post-transplant. Skin cancers in particular are one of the more common cancers that we have to deal with, and I believe our dermatologists have provided a nice talking to you about the importance of using sunscreen and preventing excessive sun exposure post-transplant. It's not just a matter of being exposed to the sun, but the medicines that we use to keep the organ healthy and prevent rejection do contribute to increased risk of skin cancers. But there are important things you can do to help prevent this, including sunscreen, seeing the dermatologist regularly, wearing long sleeves or a wide-brimmed hat if you're going to go out in the sun, and looking at your skin and looking for changes. If you see things that are growing or weren't there before, then they need to be checked out, and it's important to go see the skin doctor once or twice a year and have any lesions removed when they're small and treatable rather than wait for them to get out of hand. Other cancers that are problems, there is a condition called post-transplant lymphoproliferative disorder, or PTLD, and this happens in about 2% of liver transplant recipients. It's more common in the early years after transplant, but can occur long-term in many years after transplant. It's usually related to being on long-term medicines to suppress the immune system. The younger the person undergoing the transplant, the increased the risk of PTLD. And then also there's an association with certain viral infections that can lead to PTLD. So this is once again an important reason why we want to see you on a regular basis. We want to try to get you down over time to the least amount of medications as needed to manage your transplant, to help reduce the risk of malignancy, or reduce the chance that the cancer could get uncontrolled. A lot of adults are at increased risk of head and neck cancers, especially previous tobacco users. We require that everybody stop smoking prior to transplant, and I would hope that most people are able to abstain from going back to smoking after transplant. But this is one of the reasons why we recommend stopping, because we don't want to see you have a healthy liver and get a new shot at life with your liver and then die from a preventable cancer from tobacco use. So would recommend also that you get regular health maintenance checkups for cancers that we can screen for. So in women, breast cancer we know patients are at increased risk of this when they get into their 50s and 60s. We recommend you get a regular annual mammogram by your primary care doctor to stay up to date on your Pap smears. For both men and women, colorectal cancer continues to be one of the leading causes of cancer-related deaths in the United States, and this also can be prevented by screening with colonoscopy and having polyps removed when they're in the early stages before they become colon cancers. Cancers can be more aggressive after transplant due to your immune system not being as strong from being on the rejection medicine. So it's important to get the screening, to get it regularly, and to try to prevent becoming a victim of some of the things that we know that are out there that can contribute to your poor health.
Hello, I'm Adam Dodson, one of the inpatient transplant pharmacists, and today I will be discussing transplant medications with you. Why do you need medicines after the transplant? After the transplant, you're going to need lifelong immunosuppression. These medications, known as immunosuppressants or anti-rejection drugs, work by lowering your immune system to prevent your body from rejecting the organ. So it's going to be important that you take these medications every day. Doses cannot be missed for any reason. Missed doses can lead to rejection or loss of your new organ. These medications are going to be scheduled at certain times throughout the day to ensure that there is enough medicine in your body to protect your new organ. If you happen to miss a dose, be sure not to double up on the dose. Follow the instructions provided by your team at discharge or contact your transplant coordinator for further instructions. It's going to be very important that you stay organized with these medicines. Success after transplant really hinges on your ability to incorporate these medications into your daily lifestyle. So go ahead and find a family member or friend who can help you stay organized. Discuss methods with them of how to incorporate these medications into your lifestyle, and you can also discuss that with your transplant team. Then after transplant, if you notice that you're having any issues with these medications, be sure to discuss with us methods to help incorporate these into your life. So how many medications will you be on after the transplant? This number really will be different for every patient. In addition to the transplant medications, you may be on other medications for conditions such as high blood pressure, high cholesterol, or high blood pressure. It's important to note that your needs will change over time. Doses may be adjusted when they check lab work, or they may be added or removed. So what medications are you going to be on? After transplant, we will put you on anti-rejection drugs. The three most common that we use are tacrolimus or Prograf, mycophenolate or Cellcept, and prednisone or Deltazone. There's also other drugs that are listed on this slide that we may use after the transplant, but those are the three most common that we put patients on. In addition to the anti-rejection drugs, we will put you on anti-infection drugs in the immediate time frame after transplant. These include sulfamethoxazole trimethoprim, also abbreviated SMZ-TMP, or known as Bactrim, nystatin suspension, and valganciclovir or Valside. There's also other antiviral and antibacterial agents that we may use. This slide demonstrates a medication schedule. Medications are generally given 2 to 4 times a day after the transplant. This schedule will be provided to you at discharge with all of your medications on there to help make it easier for you to take these drugs. The example listed here shows 20 pills with morning medicine, so it may be a handful of pills after transplant, but it's important to note that your needs will change over time, so the number may decrease the further you get out from transplant. We're going to be monitoring the levels of these drugs in your body with normal lab work to make sure that you have enough on board to protect your new organ. The blood work is going to be frequent after transplant, but will decrease the further you get away from transplant. It's going to be important to keep all of your lab visits and also your clinic appointments as well. Follow your team's instructions on your clinic days for what to do with your medications. In some cases, we may get you to hold the drugs until after your lab work. Like all medications, these drugs do have potential for side effects. However, it's important to note that most patients tolerate these medications very well. Some side effects that you may encounter include abnormal kidney function, headache, tingling in your hands or feet, or a tremor, high blood sugar, high cholesterol, nausea, diarrhea, or loss of appetite, a low white blood cell count, birth defects, and it's important to discuss with your transplant team if you're planning to become pregnant, as well as trouble sleeping, mood swings, rash, or a sunburn. Like I said before, it's important just to note, most patients tolerate these medications very well. Another thing that's important for us is that lowering your immune system puts you at an increased risk of infections and also puts you at an increased risk of cancer, particularly skin cancer. So after the transplant, we're going to ask that you wear sunscreen if you're outside in the sun. These drugs do have the potential to interact with a number of other drugs. So it's going to be important that you contact your transplant team before starting any other drug that your transplant team doesn't prescribe. This includes medications prescribed by other physicians, as well as over-the-counter drugs and herbal supplements. Next question that we seem to get is, how much will the medications cost? Medication costs are going to vary depending on the number of medications that you're on after the transplant, as well as your particular insurance plan. And it's important to note that your copays will vary within your insurance plan, from brand name drugs to generic drugs to other drugs as well. Some insurances require you to cover a percentage of the drug cost. So to best determine what your potential costs are going to be after transplant, call your insurance company and provide them the list of transplant medications, especially the Prograf, Cellcept, prednisone, valganciclovir or Valsite, Bactrim, and Nystatin. The one that we typically see that if patients have issues with is typically the valganciclovir or Valsite. If you have Medicare, it's also important to find out whether or not your transplant and your immunosuppression drugs are going to be covered under Medicare Part B. Medicare Part B usually covers doctor's services, hospital outpatient services, laboratory tests, and durable medical equipment, whereas Part D typically covers outpatient prescription drugs. If you can't afford the drugs, please let us know. Some drug companies can help provide medications, but unfortunately not everyone qualifies for this kind of financial help. A social worker is available as part of your transplant team for questions about medication coverage and also to help you apply for financial assistance if you need it. It's important to note that from this point forward in the transplant process, don't change insurance companies without checking with the team to make sure that all of your medicines are going to be covered under the new insurance plan. To receive these medications, most pharmacies do not keep these medications in stock, so it's going to be imperative that you keep at least a 7-day supply on hand if possible. Some insurance companies will require you to use a specific pharmacy to fill these medications, so it's important just to double check with them. If within your insurance's network, UAB has a specialty pharmacy which fills for transplant patients that can mail the medicines to your front door. Things that you can be doing now to prepare for the transplant. First is provide the transplant team a list of all prescription drugs, over-the-counter drugs, and herbal supplements that you take, as well as your insurance information. And be sure to have your updated insurance information with you at the time of transplant so that we can relay that to the pharmacy to fill your medicines prior to discharge from the hospital. Discuss with a family member or friend how you're going to keep your medicines organized after a transplant. And call your insurance company to determine an estimated cost of these medications, especially the valganciclovir. If necessary, you can discuss how to apply for financial assistance with the Social Services Department. When you're called in for transplant, be sure to bring your current insurance cards as well as other items that you may need while you're away from home. These include your current medications, glucose meters, test strips, and items like that, comfortable shoes to walk in, and eye and ear wear. If you have any questions about the medications during your hospitalization, create a list to discuss with an inpatient pharmacist, and be prepared to pay the copays at the time of discharge. If you have any medication-related questions as you proceed in the transplant process, please feel free to contact our outpatient liver transplant pharmacist, Deanne Jones, at cdjones@uabmc.edu. Thank you for your time.
I'm Dr. Blake Phillips with the Department of Dermatology here at UAB. I wanted to take a minute and discuss skin care with you in relationship to your new transplant. By now you should be familiar with the idea of immune suppressant medications. These are the medicines that you'll be using in order to maintain your transplant. Part of the function of your immune system, in addition to fighting off infections, is to screen your body for various forms of cancer. In transplant patients, skin cancer is a common form of cancer that can be both a significant cause of discomfort as well as mortality in certain populations. Skin cancers occur at a much greater rate in patients with a transplant. Solid organ transplant patients have 65-fold increased risk of squamous cell cancer, upwards of 10-fold increased risk of basal cell skin cancer, and melanoma at 3 times the average rate of non-transplant patients. Obviously that poses a significant risk to your health, But the good news is these tend to be visible, and if you're diligent and are up to date on screening, these can be easily caught and treated without requiring a significant amount of prolonged therapy, I would say. Most of these are treated simply with surgical removal, and they don't require follow-up chemotherapy and radiation in the majority of cases. That said, who is at increased risk? Well, within the transplant population, patients with a history of previous skin cancers obviously are at the most significant increased risk for developing new skin cancers. Further risk factors are patients with a strong family history, patients with fair skin that tends to burn as opposed to tan. So if you have a history of a significant number of blistering sunburns or just a consistent pattern of sunburns over your lifetime, you will be at increased risk. You've lost the ability of your immune system by virtue of your new medications to kind of prevent and watch out for the development of skin cancers. And so that long-standing sun damage that's been under the surface and kept at bay may be allowed to develop into new precancers and then skin cancers. So how do we combat that? Generally, first and foremost, I would say if you have certain risk factors, fair skin, light eyes, growing up in the South, a strong family history, you need to be seen by a dermatologist. A lot of transplant patients travel long distances to come to UAB for their care. Here at UAB, we have a dermatology department. We are happy to see and screen transplant patients. We can coordinate your care with your transplant appointments. At the same time, if that's difficult for you, we would want you to be seen by a local dermatologist somewhere close to your home. There are numerous trained dermatologists in all areas around the country, and so if you're coming to visit us and you don't have a significantly increased risk, it's certainly fine for you to be seen by a generalist. I would say if you have a history of several skin cancers or numerous precancers that you've been treated for, it might be a wise idea to consider being seen at a facility where the physicians are more well versed in treating transplant populations. There are some slightly altered treatment protocols that we have in your context, I would say. What can you do aside from routine screening? Generally, skin cancer prevention starts with sun protection. And sun protection consists of avoidance of sun during peak hours, particularly between your 11 and 3 o'clock. Some would say 9 a.m. to 5 p.m., your working hours, when the sun is at its most intense. While that's wonderful, oftentimes daily life requires us to be out and about. We want you to enjoy life to the fullest. So the things that we can do would include sunscreens. We would want sunscreens that would say broad spectrum or UVA and UVB blocking. That will provide you the best protection against all the different subtypes of UV radiation. The other value to look at on your sunscreen bottle is the SPF number, and an SPF number of 30 or higher is what we're looking for. So if you're going to be out and about, choose a sunscreen, UVA, UVB blocking, SPF of 30 or higher, and please reapply after a couple of hours. Oftentimes people will apply and think that covers them for the entirety of the day and then end up burned at the end of the day. Even better than that, ideally, and something you should probably become accustomed to, is sun protective clothing. So long sleeves, wide-brimmed hats, and there are subspecialized lines of clothing now that have come out in recent years that you can buy at any sporting goods store that have what's called a UPF, and that's another clothing measurement for sun protective factor like you would have in sunscreen. So familiarizing yourself with various forms of sun protection can really help to decrease your risk of developing new skin cancers and the progression of precancers that you have on your skin now.
At UAB, we try to deliver personalized care and treat every patient as an individual. We'll develop personalized treatment plans and tailor our care to fit your individual needs. We believe that transplantation is a complex procedure that requires multidisciplinary care. We try to deliver the highest multidisciplinary care at UAB and believe we're an outstanding program that can serve your transplant needs. We look forward to meeting you during your evaluation and taking care of you with your end-stage liver disease and guide you through the transplant evaluation and transplant procedure itself.
Thank you for taking your time to review these videos and hope to see you soon.